Good evening again, and thank you for joining us for this first of our 5-part series on autism, where we will work to gain a better understanding of the spectrum of autism and learn about practical interventions. Today's session focuses on preschool issues in autism, sleep, and behavior. But a couple of housekeeping notes before we begin. In this Zoom platform, all attendees are muted. And while you won't be able to ask questions audibly, please note the QA function on your screen. If you have a question that is not addressed during the presentation, please feel free to submit it through the QA feature, and we will address as many questions as possible before the end of our session today. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. Please allow about 1 week to receive this link. It is now my pleasure to introduce our presenter for this session. We are very fortunate today to hear from a nationally recognized expert on autism. Dr. Max Wisnitzer is a pediatric neurologist at UH Rainbow Babies and Children's and professor of pediatrics at the Case Western Reserve University School of Medicine. Dr. Wisnitzer holds 3 board certifications, 1 in pediatrics and 2 in psychiatry and neurology, with an emphasis in both neurodevelopmental disabilities and special qualifications in child neurology. He has been serving families at Rainbow for more than 35 years. And now I'll turn it over to Dr. Wisnitzer.
Thank you for that very nice introduction, but let us get on to what the topic is. And the reason that we chose these 2 topics for the preschool years is because of feedback we've had from families that over time, when we ask, what are the things that really must be addressed because they can make or break a family unit, people always say, my child is not sleeping at night, therefore I'm not sleeping at night. Or my child has really challenging behaviors that are disruptive for the rest of the family and for the lifestyle of the family. So I figure let's have a little talk and more of an overview of what are reasons why these behaviors can occur so that we can identify also what can be done about them. So the first one we're going to talk about is sleep. And the question we ask is, what is sleep? Now, sleep by definition is a decrease in awareness and responsiveness to the external environment. Now, for instance, there's other reasons why you may become less responsive to things going on around you. Drugs can make you do that. Unfortunately, certain medical illnesses can make you do that. Disruptions in the chemistry of the body can make you do that, but those are not physiologic. In other words, it's not an expected pattern. Sleep is an expected pattern because it has a purpose. For children, it aids in brain development. There's an increased amount of sleep in young people because there's a lot of developmental changes that can occur in the brain during the sleep time itself. I'll be talking about the different stages of sleep, but REM sleep is basically the sleep state in children, and it's increased for reasons that are basically being defined. Also, when you're sleeping, it helps establish things that we have learned and things that we have remembered during the day so that they can basically be put into our long-term data banks compared to the short-term data banks. That means if you're not getting a good night's sleep, you may not have as good recall, you may not have as good learning ability as if you would were you getting a good night's sleep. Now, there's different stages to sleep. Everyone always thinks sleep is just this monomorphic or same throughout the entire night. That is not true. There are stages, and I'll show you a little slide right afterwards that shows some of these stages. There's drowsiness, which is stage 1, light sleep, which is stage 2, slow wave sleep, which basically means the brain electrical activity is much slower during that time, which is stage 3 and 4. And then there's dream sleep or REM sleep. REM stands for rapid eye movement because if we look at the individuals, the eyes are somewhat moving during that time period. And you have more non-REM sleep, stage 3 and 4 sleep in the early portions of sleep, and more dream sleep or REM sleep in the later parts of sleep, unless you're sleep deprived. If you're sleep deprived, you go into REM sleep very early. Now, here's a pattern of how sleep goes, and I'm just using my little pointer. As we sleep through the night, we basically go into the various stages. We first may go into the non-REM sleep stages, and then we go maybe into one dream state, and then we go into another one, then we go back into the non-REM sleep. But during the night, there's also time periods when there seem to be little what's called micro-arousals, and those serve a physiologic purpose. If all of us can think about this, when we're sleeping, there are times when we wake up, we have to go to the bathroom, maybe our stomachs hurt, maybe we have an earache, maybe we just don't feel well. Maybe our spouse has taken our blanket away from us and we're cold and we want it back. These are time periods where there's a microarousal and you check your external environment and you check your internal environment. And what you're looking for is to try to keep things the same as when you fell asleep. And that's an important point to remember, because I'll bring that up later on. Obviously, if my bladder is full, I wake up, I go to the bathroom. Now I'm back to the stage where I was before I fell asleep, and I can go back to sleep again. If I'm cold and I grab a blanket and put it over me, I'm now feeling better and I can go back to sleep. But there's little time periods when we do have these little arousals. They tend to occur every about 1.5 to 2 hours throughout the night. When you look at the amount of sleep that individuals have, the amount of sleep changes depending on age. Newborns sleep for about 16 to 18 hours during the day, although we may not think so because they don't necessarily have a well-established nighttime sleep pattern. They sleep for a period of hours, they eat. They sleep for a period of hours, they eat. But as time goes, and you can see that it varies between the nighttime, which is the dark color, and the daytime, which is the light color. Over time, and we can appreciate here, over time, the amount of sleep that we need diminishes and basically gets consolidated all into the nighttime. By about 3 years of age or so, naps basically are given up. Now, people still take naps when they're extra tired during the daytime. We know that. But we're talking about the routine scheduled naps that tend to occur in individuals. So we go from about 16 hours of total sleep during the day to about 8 hours of total sleep during the day, all consolidated into the nighttime. These are just important things to remember in terms of our typical sleep requirement. So what happens if you're not sleeping well? If you're not sleeping well, first of all, when we look at kids in the preschool years, there's a percentage of kids who have problems falling asleep or staying asleep or have some disturbance while they're asleep, for instance, night terrors or nightmares or sleepwalking or sleep talking that can occur. About 25% of the typical kid population will have this happen to them in the preschool years. It's a very common thing. With kids with behavior issues such as ADHD, it will go up to about 35%, or about a third of them will have some sort of disturbed sleep patterns. Individuals with intellectual disability, what we used to call mental retardation in the past, we have about 40%, but look at autism. At least 60 to 70% of those kids will have disturbances in their sleep patterns. And the disturbances in the sleep pattern that occur in that population can have negative impacts on their ability to function. What are the issues that can occur? First of all, there's cognitive or thinking issues that can occur. You have problems paying attention. You have problems being creative. In fact, you may look like you have ADHD. You have problems with organization, with time management. You just can't get your act together. And as a consequence, for children, it can really have a negative effect on their academic performance. For adults, it can clearly impact their ability to work or to maintain a home and take care of things in that setting. There are also behavioral consequences from inadequate sleep. One, and I am sure, we have all gone through these with our children. And one is that the children are overtired. They're much more emotional. They're much more labile. They blow up more easily. They cry more easily. They're more active. They're more busy. They can actually be very irritable and look unhappy. This kind of behavior not only impacts the child, but it actually impacts those around them. The third thing is if kids really don't get a good night's sleep regularly, it can have an impact on their ability to grow. They're going to be fatigued during the daytime. They may not grow well, what's called failure to thrive. They may not gain weight the way they're supposed to. They may not grow in height the way they're supposed to. And some people wonder whether a chronic lack of sleep can also have a negative effect on how your immune system works and how resistant you are to infections. So it's important that we have a good night's sleep. Now, when we look at problems with sleep, and I'm going to identify all of these, you can have problems falling asleep. The terminology is a problem with sleep initiation. You can have problems staying asleep, a problem with sleep maintenance. You can have a problem where you fall asleep early and wake up early, or fall asleep late and wake up late. That's called a sleep phase disorder. And we have to remember that there are times when people go to bed late and wake up late. For instance, 2 ages in which going to bed late is a common behavior is the adolescent years. It's not unusual for teenagers. They go to bed at 10, 11, 12, and they want to sleep in. People have actually advocated that high school should not start at like 7 or 7:30 in the morning. They should start later. And studies that have been done that have shown that when the start of high school is delayed in that manner, the kids actually learn better. On the opposite age range, in the elderly population, it's not unusual to fall asleep early and to wake up early. So that's not a sleep phase disorder because that's typical for that population. It's when something occurs that's out of whack in terms of the population. In addition, you can have problems with parasomnias, as I mentioned before, problems with night terrors, problems with sleepwalking, sleep talking, and other wetting the bed at night and things of that nature. Those really aren't increased in number in the autism population compared to the general population. So that's not something that we tend to worry about a lot. You also can have excessive sleepiness. There are disorders that are associated with excessive sleepiness that really don't impact the autism population more than they do anyone else. But it's something that we have to be aware of, but it's not part of today's talk. So one of the questions we have to ask ourselves is, if kids with autism have sleep problems, why do they occur? Why do they occur? Now, I can't go through all the reasons why these things happen. I would recommend, if anyone wants to do some good reading, the granddaddy of all the books on this topic is Richard Ferber's Solve Your Child's Sleep Problem. It's a wonderful primer. It tells you about sleep and also identifies reasons why individuals will have difficulties. There have been modifications made on it. There's other books out there, including books written for individuals with developmental disabilities, but they're all spin-offs of Dr. Ferber's work. If we look at problems with difficulties with sleep initiation, kids with autism, perhaps because of the restricted interest or repetitive behaviors, they can have problems with transitioning to bedtime. They may be resistant to any kind of a change. If I'm going to a hotel room, they're not going to sleep in the hotel room. If I'm changing the time when they're falling asleep, they don't want that. They expect to fall asleep at 7. That's when they're supposed to be going to bed. Therefore, they have a fixed behavior pattern that's there. There can actually be separation anxiety that occurs in the population in terms of separating from the parent. They may not understand the rules of what we're supposed to be doing in terms of sleep itself. There can be fears that do not allow them to fall asleep. A great story that I heard about from one of my parents a long time ago was a child had gone to Disney and came back and refused to fall asleep. Turns out the child had a negative experience at Disney with the characters. You know, they have the 7-foot characters. Now they're more 5 foot, but they used to be 7 foot. And the Mickey Mouse character, which the kid loved, scared the kid, got extremely scared by it. The difficulty, his room was decorated in Mickey Mouse. So all this really did was brought back the experience he had at Disney. Once the parents got rid of all the Mickey Mouse representations in his bedroom, he fell asleep quite nicely. You can have kids who have a high level of arousal. They said, this can't unwind. They're very active. They're very sensitive to stimuli in the environment. Any little noise or creak bothers them. Those are things that we have to look for. So you have to ask questions why they have problems falling asleep. And you can also have problems staying asleep. One of the key rules for individuals with sleep is how I fall asleep is how I stay asleep, what I had mentioned beforehand. Therefore, if the child falls asleep with the TV on, may wake up 2 or 3 hours later and say, why isn't the TV? Why isn't my movie on? Why isn't my tape on? For those of you who remember tapes. or CDs or whatever you want to call, whatever term we want to use. Or if a parent is in the room and the child will only fall asleep with the parent and the parent leaves afterwards, the child will wake up and say, where's my parent? And go looking for the parent. The child may have a problem with sleep maintenance if you change their environment. If they fall asleep in the living room watching TV and you carry them and bring them into their bedroom, they may wake up a few hours later and say, this is not where I fell asleep, and go back into the living room and may actually stay up the rest of the night because things may be disrupted. Again, they may develop a habit. I wake up at 2 a.m. every morning because it turns into a habit behavior that can occur. I've had some individuals, my higher functioning individuals, are so worried about I'm supposed to get up at 6 o'clock that they wake up every hour on the hour to check the clock. See, am I, have I overslept my clock? Have I overslept my clock? There's a list of other things that are there. Nutrition, which means they're hungry, something bothers them in that regard, can be a reason why kids wake up. Illness, like any other child, illness can make them wake up. My ear hurts, my stomach hurts, things of this nature. For interventions for this, you first, if you possibly can, identify the underlying condition that's driving it. If they've got excessive anxiety, address the anxiety. If their ear hurts, address the ear. If they've got asthma, or if they've got reflux, and those are issues that are waking them up or making it difficult to fall asleep, deal with those. However, the other thing you do is you have to look at their behaviors. Do they have a good set bedtime routine, which is what we call appropriate sleep hygiene? And that means that you have a set bedtime, you have a routine you go through as you go to sleep. It's not chaotic. I'm not falling asleep in the living room watching television with everybody else in the family running around me. I'll make environmental modifications if you need them. I had one patient of mine who had problems staying asleep because there was a neon sign that was flashing all night outside his window. This is where they lived. The parents smartly got darkening curtains to put over that window, and now the child was able to sleep. Also, parent education is very important. That's why I recommended Ferber's book. If you understand what's going on with sleep, you can then start working on strategies to fix the issue that's there. Pharmacotherapy or medication therapy can also be used. So I mentioned some of these interventions about identifying the triggers, and here's just a list for people if they want to go through that list. By the way, allergies is also a big one that we always have to remember happens at certain times of the year in that regard. And here's the behavioral interventions that we have to do in terms of the decreasing stimulation, getting caregivers out of the room before the child falls asleep so the child learns to fall asleep by himself. If the bedtime, I have some children, if they're 12, 13 years old, you're not going to be able to put them to bed at 7 p.m. Their body isn't ready to fall asleep then. You've got to basically shift the sleep clock shift their sleep a little bit later so it's easier for them to fall asleep. If they're sleeping in too late in the morning, wake them up early so their clocks will gradually shift back to the way you want it. Give them positive reinforcements for things that we want them to do so that they will sleep and get a good night's sleep in that situation. We want them also to be able to associate a certain environment with sleep in that regard, so that they're used to that. So if you set up the schedule, you maintain the same sleep environment, transition the adults out, many times that can be extremely helpful in these circumstances. There are medications that people talk about. Guidelines that have come out have told us that melatonin can be helpful and has been helpful as shown in research studies. Interestingly, in the same guideline, there were comments about the use of weighted blankets, which can have some benefit for these individuals. For the ones that are more like overstimulated or have some what we call sensory issues. And that's a topic for another time to discuss that whole area. But probably the second most common medicine to be used is clonidine. Originally developed as a blood pressure medicine, has a side effect of making you tired, but it also can calm people. It has the effect of reducing some of the anxiety that's there. People will use antihistamines such as diphenhydramine or Benadryl. Some of the kids can get a little bit wired on it, but when they don't, it can make you sleepy. There are other antihistamines that can be used. A more popular one nowadays is hydroxyzine or Vistaril that's being used. And there's a whole list of other ones that people have to use them. We try to avoid using them. Some of these medication choices are good to help people fall asleep. Some of these medication choices are good for keeping people asleep. One of the things that we do not use in the preschool years is the typical sleep medicines we use for the adults. We don't use things like zolpidem or any of the other benzodiazepine-based medications. For young children, it either doesn't work or it actually has the opposite effect for obvious reason. You're not dealing with a mature brain like you're dealing with an adult. So really saying, give me an adult sleeping pill is really not going to fix the problem. Usually it's a problem that can be fixed by sitting back, watching, and figuring out what's driving the sleep behaviors. So in summary, sleep disturbances and autism, up to 80% of the population have them, usually affects sleep onset and continuing to sleep through the night. If they don't sleep well at night, they usually do not function well during the daytime. So this can contribute to or exacerbate or even cause behavioral disturbances that occur in the population. It can impact negatively on their learning. We have to understand that from research studies that have been done, sleep patterns in the ASD population are somewhat immature for age, and that they're influenced by some of the comorbid conditions, coexisting conditions that the children can have, and that I'll be discussing in the next section. And that there are interventions that are available. We try to go after behavioral therapies. We've got a great group of people here at Rainbow who can help with those areas. Medication can be used when needed. Sometimes we use it because we have to get the kids to sleep so the family can sleep. Once the family can sleep, we can have them then implement the behavioral strategies much more successfully. So now let's move on. What are the behaviors that we're talking about in the preschool years when we're talking about this population? And again, as I stated before, when kids have behavior problems, parents are not happy. So problem behaviors just in the autism population in general can include actions such as being aggressive. That can be being verbally aggressive for verbal children, can be physically aggressive, and you can be aggressive towards other people. You can be aggressive towards pets. You can be aggressive towards possessions. And you can be aggressive towards the house. In other words, anything, either you want to think of it animate or inanimate objects in that regard. So we've got kids who make walls and doors and actually make holes in doors and walls. We have children who break objects or throw objects or bite or hit or kick. They try to run away. These basically are manifested as tantrums that can occur in multiple settings, depending on the trigger and on the environment that's there at that time. They can just have agitation. They can have self-injury, especially in the lower functioning population, the nonverbal lower function or minimally verbal population. Many times they'll manifest self-injurious behavior. They'll bite themselves, they'll hit themselves. That's very stressful for families. And many times that behavior becomes consolidated because people react and respond to it. And the kids say to themselves, if I bite myself, I can get their attention. And we know that's a maladaptive behavior, but it's better than no attention at all. Is basically how the kids think through it in their minds. You can have irritability in that regard. The kids can be very active. We know the ones who basically nag and ask for things over and over again, or have to have things done a certain way. So there's lots of problem behaviors that we can see in the ASD population. When we have this happening, when we look at the disruptive behavior, you basically have to look at the environment around them at large and ask yourself what's driving the behavior. Is there a biologic basis to it? We'll talk about some of those in a little bit. Is there an environmental aspect? An environmental aspect. For instance, not necessarily for the ASD population, but for just kids in general. I mean, if I live in an environment where I see a lot of aggression, where I see a lot of violence, it may lead to that same kind of behavior in the children because that's what's being modeled for them. That's there. There can be psychosocial reasons, which has to do partially with parenting issues, as well as other issues in their environment. But those are all things that we have to look at because the interventions will vary. So, for instance, if I've got a child whose parents have not modeled an appropriate way to react or respond to stress, and they manifest it by aggression, which we know can't happen, all the medicines in the world are not going to fix that child. We have to do a behavioral intervention there. However, if I've got a child who in part is aggressive because the child's impulsive due to ADHD, then managing the ADHD many times can reduce that aggression to manageable levels, and then you can get behavior plans in place to basically teach the child more appropriate ways to respond and react to events in the environment. So if you're looking for disruptive behavior causes, there can be behavioral reasons why they occur, medical reasons why they occur, and psychiatric. And here's a little table that I've used for years, and it actually finally got published in an article in Lancet Neurology, that if you look at the behavioral causes, these are for the ASD population, this makes sense. It could be the fact that they're using the behavior as a communicative tool. It could be that this is just the behavior that occurs because this is the child's functional level. No one is surprised when a child is in the terrible 2s or the worst 3s. And that the kids, when they're working on self-control and self-regulation, that you may have outbursts and behavioral issues. If the child is 13 years old, but mentally at a 2.5-year-old level, this is the kind of behavior you may see. It may be attention seeking, and maybe that they've learned, if I do this enough, I'm going to get out of what people want me to do, which means it's a learned response. It may be driven by the fact that something is happening in the environment and they don't like it. It stresses them out too much because they don't like change. And therefore, they're trying to avoid that. They may not understand what's going on, or it just may be stress in general. They've got they're hyper alert to start with, and they get stressed in that regard. These are some of the reasons that may be there. ADHD can have disruptive behavior, oppositional defiant disorder, many times in the young children driven either by ADHD or anxiety, can have disruptive behaviors. I'm not going to talk about conduct disorder, that's older children. Anxiety itself, and yes, preschool children can have anxiety. It's there. Many times people call it and say they have sensory issues, but if you look at the sensory issues, many times that's anxiety-based. They can have mood disturbances. It's not common, but you can have mood disturbances, usually depressed mood, where they're irritable and more aggressive in that regard. Psychosis is extremely rare in the preschool population, and if it would be happening, it almost be, in that population, it would probably be drug-induced. So it's not something we worry about. When for medical causes, after individuals have had seizures, when they're a little bit disoriented, you can have reactive aggression in terms of going after something because something's bothering me. I already mentioned sleep, and there's a whole list of other reasons why these things can happen, especially if your hearing isn't good, if your vision isn't good. And what we're talking about here for this population, we're talking about disruptive behavior, we're talking about reactive disruptive behavior. In other words, you're reacting to something that's going on around you. It's not a child who deliberately plans what they're doing, which is not common in the preschool years. That's usually older individuals. And the aggression and the behavioral problems that occur in that population are basically deliberate and focused in that regard. That is not what we're talking about here. So if you're looking at problem behaviors in ADHD, here's in the preschool years, here's some of the common reasons that I may see it in the preschoolers. We've already talked about sleep disturbances, and we've talked about some unclear etiologies. And there are reasons why we sometimes can't identify it, especially if the kids aren't verbal, because we can't get the feedback. And no matter how much we analyze the situation, it's hard to identify. But let's talk about some of the others. You can have problems paying attention. Now we remember, problems paying attention does not automatically mean ADHD. You can have a problem paying attention because you have a short attention span. You can have problems paying attention because you have a heightened anxiety level. And if you're very anxious, it's difficult to focus on things going on around you. You can have problems paying attention because you're depressed. And people who are depressed, again, have problems focusing. You can have problems paying attention because you've got social withdrawal. For instance, children who have social anxiety act like they're not interested in interacting because it's too stressful to interact in those regards. They may not understand what's going on. And all of us, if I was giving this lecture in Swahili, the odds are good that the majority of the listeners after a while would get extremely bored and say to themselves, I don't understand a word of what's happening. I gotta go play Candy Crush or something like that. So lack of understanding and interest may also be a trigger, even in this population. And we have to basically make sure we sort them out. If you have ADHD, by definition, ADHD is individuals who have inattention for their developmental level. So if I'm a 5-year-old with the intelligence of a 5-year-old, I should have the attention span of a 5-year-old. If I'm a 5-year-old with the intelligence of a 2.5-year-old, I should have the attention span of a 2.5-year-old. These kids are active, which means they can be fidgety, all the way to bouncing off the walls. They can be verbally active or overactive if they talk. They're impulsive, which means you do things without thinking. You can have behavioral impulsivity. You can have physical impulsivity, like running across the street without looking for cars. You can have verbal impulsivity, saying things without thinking to yourself, should I be saying this or not? And they have easy distractibility. You're symptomatic in 2 or more environments. It's not caused by other reasons. For instance, like a medication effect. It's been present for at least 6 months. And it used to be onset prior to age 7 years. It's actually now been changed 12 years that the onset. Although if I really take a good history with these individuals, they all have symptoms of it before age 12 years. The question is, when do they rise up to the level that they meet diagnostic criteria? But if you ask good questions, it's almost impossible that a child will be asymptomatic and then at 12 years old becomes symptomatic with ADHD. If that happens, we start looking for other reasons. Anxiety is defined as apprehensive anticipation of future danger or misfortune out of proportion to the perceived threat. These are big words that just basically means that we're stressed, we're nervous, we're anxious, and whatever's going on around us should not be provoking that reaction. If someone holds a gun to my head and I get very anxious, that is not an anxiety disorder. That is appropriate response to what's going on. But if a little chihuahua walks in the room and someone freaks out, or a bee is running around, and a child freaks out because of that, that's anxiety because it's out of proportion to what the stimulus is. The perceived danger could be internal or external. It could be something going on around you or something that you think may be wrong with you. Individuals come in to say to me, I think I'm dying because my stomach hurts. I must have a brain tumor because I've got a headache. And that drives some of the anxiety. There's physical features that are present and can be good markers for this. For the older individuals that complain of headache, they have an increased heart rate, palms are sweaty, they can complain that they have shortness of breath. The ears might turn bright red in this regard, and those are things that you look for because the pupils may dilate because you have an adrenaline surge that's going on. And we can tell them calm down. We can tell them to calm down. They're not going to relax because this is out of their control. This is out of their control. You know, it's out of proportion. This is really a true disorder. So we have, instead of saying words, calm down, calm down, calm down, we have to teach them how to control it in that regard, if it's possible for doing so. So there's 7 kinds of anxiety disorders. There's separation anxiety, where you're basically fearful of being without a significant other. In this case, usually it's the parent of the child. Generalized anxiety disorder, where basically lots of things in the environment basically stress you out. One of the markers that I have noticed for generalized anxiety disorder is that children frequently check on their parents. Whether they're at home, they check where the parent is at home. If the parent is out, and this is obviously older children. If the parent is out, they may call and say, where are you? Are you okay? Things of this nature. There can be social anxiety, which basically means a problem interacting with others. Many times it's for fear of getting negative response or feedback. I'm going to do something that's going to be criticized by the other person. I'm going to say something or do some action. Therefore, I'm so scared it's going to happen, I'm going to basically stick to myself. There are specific fears that are present. And the DSM-5 lumps obsessive compulsive disorder in a slightly different category, but for all intents and purposes, since it generates anxiety, OCD can be there. And yes, preschool children can have obsessive compulsive behavior. And they can have obsessive compulsive behaviors to the point that it really interferes with their function. Whether it's issues such as how my clothing fits me, or it's issues such as food touching on a plate, or it's issues such as items being moved in the room. All these things have been reported to occur in this population and respond to treatment. Tic disorder, basically a movement disorder, is a sudden, rapid, recurrent, non-rhythmic movement. Basically, it's very fast. It can either be vocal, which basically means that a sound that you make, for instance, a throat clearing, a cough, a sniff, a snort, or it can be a motor activity, such as a shoulder shrug, an eye blink, eye rolling, facial grimacing, or more complex actions, such as certain touching behaviors or certain actions or movements that people have to do. When you talk to people who have tics, and ask them why are they, why are these movements occurring, they'll usually say to you that before the tick occurs, they have some feeling or some urge, and the movement that they make, whether it's the noise that they make or the physical motion that they make, is an effort to help relieve the stress or the anxiety or the bad feeling that is present from that urge or impulse. In a way, tick disorder is like I always tell parents, tick disorders is the tails to the heads of obsessive compulsive disorder, because they've got it's basically the same biology behind them, but it's manifesting in somewhat different ways. Studies have shown that many children will have tics. Studies have shown that the kids were in 4th, 5th grade type ages, that up to about 20% per year will have a tic, but it's usually temporary or transient. If you have tics that are going on for more than a year, they're going on for more than a year. If you're basically having a motor tic of some kind or a vocal tic of some kind, it may wax and wane, maybe more at certain times and less at others. But if it's going on for more than a year, it's considered to be a chronic tic disorder. If you've got both vocal and motor tics that have been present for more than a year, that's Tourette's syndrome. So all Tourette's syndrome really is basically a chronic tic disorder. Only a minority of Tourette's syndrome patients have the behaviors that maybe you see in various media in terms of the use of obscenities and stuff like that. That's not the common one that occurs. It's not very common in the population. That's all that people are afraid of. Most of the time, when older children are using obscenities, it's not because they have tics. It's because they're using obscenities. Now, why do I throw tic disorder in here? Because about 10% of individuals with chronic tic disorders will also have behavioral disturbances. They'll have problems with mood regulation, self-control and self-regulation regarding mood. In those cases, with those children, they can really be very disruptive, temperamental, explosive, and it's not the tics that are the problem, it's the behavior that's present that is the problem and needs to be remediated. Many times when we ask good close questions, you find out that behavior is related more towards a coexisting anxiety disorder or obsessive compulsive disorder. And if you manage those, they tend to get better. And lastly, we talk about self-injurious behaviors in this population. And I mentioned before what these self-injurious behaviors are. This is when the children hit themselves, bite themselves, bang their heads against surfaces, for instance, repetitive head banging, things of this nature. Now, it's really interesting that with the kids who bang their heads, it's very rare, if ever, that they actually have any kind of reaction like they have a concussion in that regard. It's because that's the head banging that occurs in a deliberate manner when a child is acting out is not the same thing as if you bang your head in a motor vehicle accident or because you fell from a height or things of that nature. It's a more controlled action, and it tends not to have necessarily the same sequelae, but is extremely frightening for caregivers when they see that. So when we have these self-injurious behaviors that are occurring, the question we have to ask ourselves is not necessarily how do we stop it, but before that, the first question we ask is, why is it happening? And these behaviors can occur for a variety of reasons. One is, especially in the minimally verbal population or individuals who have inadequate language at that time, that it's a communication device. I'm upset. This is the way I can tell you I'm upset. Or something else is bothering me, something on that level. So I do this, and I've learned if I do this, I can get attention from the people. Number two, if I do this action, I get removed from an environment that I find stressful or I don't want to be in, or you're making a demand on me, which I probably could do, but I don't want to do it. So I'll hit myself enough times, you'll remove me from that situation, and I don't have to fulfill that demand. Number three, it's attention seeking. I'm sitting here, nothing's going on, nothing's happening. I want your attention. If I hit myself, I know people respond. If I bite myself, I know people respond, so I'll keep doing that. And lastly, it can actually be a compulsive behavior. There are, it almost turns into a fixed routine, and individuals would do this, and they hit themselves in that regard. Interestingly, some people believe that for this population, if the ones who hit excessively, or they bite themselves excessively, so that they actually leave areas of injury that are identifiable and present, that they may have a decreased response to the painful nature of that self-injurious behavior. And in those cases that people talk about using medications such as naltrexone, that from a hypothetical, theoretical manner masks some of the pain receptors in the brain and may actually make these individuals stop doing this behavior. Occasionally it does work. It's amazing when it does work. But there can be, it can be in a compulsive manner, but it can do that. If it truly is compulsive, then you basically have to work it in that regard. And with these behaviors, for the most part, if they're not driven by some of the other conditions that I highlighted beforehand, the best intervention is identifying why it's happening and then remediating it or putting a remedy in place. So giving them an alternate means of communication, giving them a better way to tell you, I want your attention, I need something that's going on. Giving them a better way of saying, I don't like what's going on here, this is too stressful, I need a different way of working or coping in this environment. And if we do that, many times you'll find that you can get a very positive effect and a reduction in the self-injurious behaviors that are present. After a while, self-injurious behaviors can literally become fixated, that they become almost like a habit that's there. This is the way I'm going to react and I'm going to respond. And it's much more difficult to break. If you catch it early on, it's much easier than if it's years later. So I'm going to stop here right now. And I think that if people have questions, I was told I should give about 15 to 20 minutes so that we can address questions that people have. I'll be happy to entertain them.
Yes, thank you, Dr. Wisnitzer. And we have had several questions come in. And some of these are related to the early part of your talk. But one attendee is asking, what is the difference between autism and Asperger's?
That is I like that question because now I'm going to do a little education. In the term Asperger's syndrome, Asperger disorder, describes a group of individuals who were put into the Diagnostic and Statistical Manual, fourth edition. At that time, there was also a category of pervasive developmental disorder, and Asperger's disorder was one of the subtypes within there. Autistic disorder was one of the subtypes. PDD-NOS, not otherwise specified, was one of the subtypes. And believe it or not, even Rett syndrome was one of the subtypes that was there. When research studies were being done, we looked at individuals with Asperger's syndrome who have normal or near normal intelligence and basically are verbal, but they still have all the hallmarks of what we see in an autism spectrum disorder. They've got significant impairment, qualitative impairment in socialization and social communication. They've got restricted interest in repetitive behaviors. The restricted interest may be at higher functioning. They may be into the solar system. It's not that they're into spinning objects, they're into the solar system or biology or certain aspects of that. Think of that kind of an individual like the Sheldon character in Big Bang Theory. So what happened is, one of the reasons it got put in there was they said, is this a viable diagnosis? Can it stand on its own feet? Research work was being done that showed that if we looked at high-functioning individuals with high-functioning autistic disorder at an older age, and we looked at individuals with Asperger's disorder at an older age, there really wasn't a difference between them when it came to their test results or their biologic testing or anything else of that nature. But the nail in the coffin that really put that title away was a beautiful research study that was done in which they took information from, I think it was 13, don't hold me to the exact number, but 13 autism centers around the country were asked to basically evaluate their clients or their patients. And what they did was they used the autism diagnostic interview and the autism diagnostic observation schedule, and to classify the individuals either as having autistic disorder, basically Asperger's disorder, or PDD-NOS, pervasive developmental disorder not otherwise specified. And when they looked at the profiles on the ADI and the ADOS, the scoring on that and the classification on that was basically about the same across all the centers in the country. Then they said, give us one of your well-trained clinicians and ask them to put a clinical diagnosis from the DSM-4, in this case, on these individuals. And there was a wide scatter. One center had a lot of Asperger's disorder. Another center had a lot of autistic disorder. Another center had a lot of PDD and OS. So what happened was that everyone recognized that they were in the ballpark, but didn't necessarily put them at the same base. Basically, they were talking about the same creature, but there was a lot of variability in how people perceived it. So that's the reason why we no longer have these subtypes. We just call it autism spectrum disorder, because we recognize that really there isn't much of a difference between all these little groups. It's just a semantic or word difference that's present. One of the big giveaways for me was I have patients of mine that I remember when I saw them when they were 3 years old, they met all the criteria for autistic disorder, all the criteria, everything. And then someone else evaluates them at 13 and says, well, they have Asperger's syndrome. We were looking at the same individual at a different age, and we use different terms for it. And that's why we basically dropped the Asperger's syndrome. We dropped the classic term of autistic disorder, and we call it autism spectrum disorder, recognizing that the presentation will shift and change as the individuals get older in terms of how they look, how they socialize, how they communicate, and even their behaviors that they have. And that there can be a variability that's there, that the 3 or 4 people come in may apply a slightly different label for what is the same individual. Hope that answers the question.
Yes, I think it more than answered the question. Thank you. And
Sure.
This one relates back to earlier when you were talking about sleep. This individual has a 4-year-old who's sleeping from 9 p.m. to 8 a.m. Is that good or is that too much?
That's wonderful. I know parents who would kill to have a child sleeping like that. Whatever you're doing, keep doing it. That's all I would say.
Okay.
And actually, that is an adequate amount of sleep. But remember, the numbers that I showed you on that table were the average numbers. There are some people who need less sleep. For instance, we probably all know adult individuals who can get away with 6 hours of sleep every night, and that's all they need. There are other adults who need 10 to 12 hours of sleep every night, otherwise they can't function. So the 8 hours for an adult is an average number. In the same way, for a child who's sleeping 11 hours a night, that's perfectly fine. If that's what the child needs, then that's what the body's telling them they should have.
Wonderful. And this question, any suggestions to transition an adult out for a minimally verbal child's bedroom? Not sure the relative language is strong enough
The issue may be that a minimally verbal adult transition a parent out of the room. I would tell you a few things. One is, again, read Richard Ferber's book, Solve Your Child's Sleep Problem. There is a set routine of how you slowly get yourself out of the room. There's a technique where you sit by the bedside for a few nights and you move the chair closer to the door until basically you're out the door. Sometimes you've got to put some little small barricades. I have some parents who will put things like the child-proof gates to prevent babies from falling down the steps, put it across the doors so the child doesn't wander at night, or things of that nature, and they get the signal. But many times that by basically getting the adult out of the room, it will help the child fall asleep by themselves. And then you've got to work, then they may have established the habit of waking up in the middle of the night, and that's something we just have to escort the child back to the bedroom, and again, get the adult out of there before the child falls asleep. If you have any issues or questions about that, we have some very good behavioral sleep people who can help work on those behaviors.
Wonderful. And this question, do you recommend naps for preschool children with ASD that also has nighttime sleep disturbances?
No, it depends on the age. If you've got a 4-year-old who has a nighttime sleep disturbance, the reason they're napping during the day is because they're having an inadequate amount of sleep at night. The goal there is not necessarily to let them nap during the daytime, but to consolidate and improve their sleep at night so they no longer need the daytime nap.
Okay. All right. And this relates to some of the different behaviors. This participant has a child with head banging with nonverbal 4-year-old. this individual wonders if this is serious. It sometimes appears to be attention seeking.
It's not serious. Think of it as a behavior, and it's a behavior that can be addressed. Sometimes it goes through a phase. Sometimes if the child is headbanging, you have to sit back and ask when it happens, why it happens, and then put interventions in place to try to remediate it or to basically lessen it so it no longer has any value. If it is attention seeking and you ignore it, but you give the child, the moment it stops, you give the child a different way of communicating that the child wants to communicate, most children will basically substitute what works compared to what doesn't work.
Okay. And this question, do you ever see anxiety and rigidity go hand in hand with children, particularly who are high functioning ASD? And then what are some treatments?
The answer is definitely yes. In fact, if you look at higher functioning individuals, the two problems that seem to occur more often than expected than in the general population is those individuals can have problems paying attention, staying focused, being on task. They have ADHD and they have some type of anxiety disorder. And with the higher functioning individuals, you have the opportunity to work with them for the anxiety, to teach them the skills of how to cope and how to react. And that's usually what's recommended. There are some good strategies that can be used. It's beyond today's talk in order to discuss them, but they do exist. If that doesn't work and the anxiety really rises to the level of major interference in day-to-day functioning, then you basically would try some medication for anxiety, usually either an SSRI, something like a Prozac Zoloft type of a drug, or buspirone or hydroxyzine. Everyone has their own little favorites. It's not like one's better than the other. And the goal of that therapy is to reduce the anxiety to the point that the individual can learn to cope with skills. That's always the goal, because medication by itself does not teach you how to cope. It just makes you more calmer so that you can develop those positive skills.
Okay, in this question, what are some good coping skills to try with self-injury?
Again, for self-injury, it depends. It's not coping skills. It depends why the child is doing the self-injurious behavior. Ultimately, that's what it comes on. First thing you do is you have to work with somebody, a behavioral therapist, where you live sometimes dictates who you work with and where the resources are available.
Okay.
But you really have to identify the reason why. Once you identify the reason why, then you can address the fix.
Okay. This question, is it better to stay in ABA therapy or go to preschool environment with IEP?
Both, if it's possible. When we did a review of ABA, classic ABA therapy, we found that it's a minority of individuals who've really shown improvement. So if you're doing things like ABA, and I would say you give it 3 months, see if there's a significant change or improvement in the child's developmental trajectory, which means is the child now progressing faster since the ABA has been started compared to before. If it isn't, then you've got to reevaluate and say, what are we doing? What should we change? What needs to be done? Some children do much better in the preschool setting. Some children do better with the ABA. It depends on the individual child. And unfortunately, we don't have any, it also depends in the preschool setting, what kind of interventions they're using, what strategies they're using. Are they autism specific strategies that have been shown to be helpful? But we don't have a magic, we don't have the magic 8 ball that you could roll and we'll give you the automatic answers to which one to use. You basically have to try.
Okay. We have a multidisciplinary team for our child with autism. What type of provider is best equipped for us to approach regarding sleep concerns?
Normally in those cases, it's going to be if you're dealing with an individual with an autism spectrum disorder, sometimes some of the time, basically it's someone who knows autism. Let's just stick that way. It could be a pediatrician, could be developmental behavioral a pediatrician. It could be a child neurologist. It could be a child psychiatrist, someone who knows autism. If it goes beyond the level, then basically you can work with the local the sleep clinic, like we have at Rainbow, where they're used to dealing with a lot of individuals with developmental disabilities. As I saw in my slide before, sleep disturbances occur more commonly in that population. So you really have to ask the question, who best can do it?
Okay. We have this question. What tools do you have to calm down a child that has been triggered, especially if the trigger is wanting a stimulus they are being denied?
Depends on the child's age, depends on what the child is doing. And many times the problem is once a child gets revved up, it's very hard to unrev them. The best thing to do in those cases is have the child have teach the child in between these events, teach the child a different skill or strategy for communicating their upset that is more socially appropriate. Otherwise, sometimes it's very difficult to calm them down. You may have to put them in a little timeout area. What I mean by timeout is not a punishment, but an area that basically lets them cool off for what's going on. The worst thing you can do is give them what they want if you think it's not appropriate. Because that what that does is it teaches them, when I want something, I have a temper tantrum and I get what I want. And if in those cases, again, work with somebody, if that's challenging, whether work with the school, work with a psychologist, work with a therapist, work with someone that can basically help you analyze the situation and put an intervention in play.
Okay. We have a couple questions from two different participants relating to melatonin. One asks if melatonin is appropriate to give to a child with autism, and another that says melatonin makes my child agitated. It's like he is sleepy and doesn't know how to deal with it.
Well, I can't comment on the second one because I don't know about the dosing. I don't know what was being given. But for the first one, I can. Yes, the guidelines that were published last year basically state melatonin up to 10 milligrams is an appropriate treatment to use for children who have problems falling asleep, kids with ASD. The issue is you've got to find a melatonin. The recommendation that was made was get pharmaceutical grade melatonin, but there really isn't much of any of that. Most of the melatonin that's being sold in the country today is perfectly fine. Very rarely do you find that the bottle does not contain what they claim it contains, or that it has additional stuff in there that shouldn't be in there. So you should feel comfortable, get a store brand, it comes as melt tabs, comes as gummies, comes as tablets, comes as liquid, you name it, the disintegrating tablet, you name it, it comes in that way. And try it out. It doesn't work for everyone, but when it works, it can be very, very helpful. And it should be given about 30 to 60 minutes before the desired bedtime, the time you really want the kids to fall asleep. If the child is resisting because the medicine is making them somewhat tired, then the question is, did we dose enough? Or is there something else going on that makes the child behave that way?
Okay. And this is probably going to be one of our last questions. This caller our attendee has a 3.5-year-old boy, and she states that if he sleeps before 1 a.m., he wakes up after 2 to 3 hours of sleep, then is up for 6 hours before falling asleep again. They tried low-dose melatonin for his pediatrician, but it didn't help. We tried to wake him early, and then he will nap early and then stays up until 3 to 4 a.m. Is there anything we can do?
Yeah, I would recommend them working with one of the sleep specialists, getting a consult at the sleep clinic. This is not something I can answer in 2 minutes.
Yeah,
it requires more history and details regarding what the sleep environment is like, what other strategies have been employed. For instance, I've had parents tell me, when screen time is taken away and things of this nature, the kids can fall asleep more easily. There's a lot of different things that have to be addressed here. So the simplest is get a consult.
Right, okay. And this participant asks, if you suspect a child with ASD has a sleep disorder, how does the parent go about finding this out, I guess, definitively?
Well, it's very easy. It's very easy. If the child basically is not sleeping the amount of time the child should be sleeping, or has a disruptive or disturbed sleep pattern in such a way that it interferes with the child's daytime functioning because the child is tired. That's really what it is. If the child sleeps 8 hours every night and looks really good during the daytime, maybe that's all the child needs. So the question is, you have to look at is there a negative impact from the amount of sleep that the child has, or is it a disruptive sleep pattern that's present?
Okay. And you know what? It is 6 o'clock, Dr. Wisnitzer. We have 30 questions in the queue. Are you able to stay on till 6:05? We can answer.
Yes, we can stay on for a little bit longer.
Okay, great. All right, this question. At what age do you think it's appropriate to start a child with autism on medicine for maladaptive or OCD behaviors? Is 3 or 4 too young?
No. That's a simple question. The answer is no.
Okay.
If the behaviors are of sufficient severity that they're having a really bad negative impact and behavioral strategies are not doing what you want them to do. I think that's that I understand the reason for the question. It's not that you're glibly or without great thought starting a medication. You've got to give it a lot of consideration. But it's the same thing as the extremely ADHD hyperactive 3 and 4-year-olds, that behaviors are so bad that they're actually putting themselves at risk for physical injury. Everyone would agree, anyone who works with ADHD on a regular basis would agree those kids are candidates for medication. There's actually guidelines from the American Academy of Pediatrics that also agree on that. So the answer is, if it's really negative, do something about it.
Okay. Here's a question that's different. I have a high-functioning ASD 3-year-old who no longer seems to be able to handle going into the gymnasium at schools where she had previously enjoyed it, but now cries and screams when she gets near the room. There's no real question, but do you have a comment?
I understand the question. See, the answer to that would be, one question would be, what changed? What was different? Normally, when something like that happens, you had a negative experience. If the child maybe has an element of some anxiety, and you had a negative experience, so the child is fearful that whatever that negative experience is will repeat itself again when I go into that environment. Therefore, I want to avoid the environment. An equivalent to that would be if a child covers their ears every time a train goes by. You may find that when they walk past the train track, they will automatically cover their ears, even though there's no train around there. In those cases, you basically have to ask yourself, what was it that bothered the child and how could it be remedied? Are there behavioral strategies that are needed, or is more than that needed?
Okay. All right, this could be a quick one. Thoughts on CBD oil to assist in calming?
There's a lot of anecdotal reports. The problem is that, number one, CBD oil can make you tired. Occasionally, it really does have an impact, but we don't understand it. But there's a lot of negatives to CBD oil. You don't know what's in the vial. You don't know about the potency, even though it may be checked. When the FDA went into Colorado and checked containers of CBD oil, it turns out that a sizable number of the ones that they checked didn't contain the amount that they said they contained, which may not be good for those individuals. Secondly, while we have good data about CBD oil for things such as epilepsy and conditions such as that, the data for the use for treatment of anxiety disorders is still being generated. That said, if people want to do a little trial and can get some good guidance and understand the doses that need to be used, I would not ask the people who sell it to them what the dose should be. I don't really believe that they know what the doses are, but there is research that's being done that suggests what doses may be there. It's always worth it. It's not going to hurt you to do that. But if the child is on other medications, remember, CBD oil can affect the blood levels of certain other medicines. So before you start, you should talk to the person who's prescribing the other medicines and say, can there be an interaction?
Okay, Dr. Wizitzer, thank you so much. That was our last question. We have more in the queue, unfortunately, but no time to get to them. But I do want to enclose, just thank you for your time in sharing this valuable question. We had many thank yous come in through the queue. And audience, thank you too for your questions and your attention. And just a couple reminders for you. We will email that link to you. Many of you came after we started. So just a reminder that you will get a link in the mail with the recorded session for today's talk. And that will take about a week to get to you. And if you would like more information on the Rainbow Autism Center, visit our website at uhrainbow.org/autism. Or if you'd like to schedule an appointment with a Rainbow babies and children's expert, it could be either in the area of neurology or developmental behavioral pediatrics, or even in sleep medicine, please call 440-596-5556. And we also have a link for you there to our very information-packed website on COVID in kids that you see the URL there. It's been a very important tool for parents these days. We get lots of visits, and it's there as a resource for you. So this concludes today's session. Thank you so much for attending, and have a great evening.